Good afternoon. Thank you to those who have joined. It looks like we're still waiting for a few more people, so we will just give it another minute or so. Thank you. If you are a committee member, if you would please put your name in the comments. And if you are a committee member on the phone, if you would unmute yourself and let us know that you are here. Thank you.
Welcome, everybody. Just a reminder, if you're a member of the Medicaid Advisory Committee, to put your name in the chat, and we'll get started in just a minute. Sharon, are you able to see if we have a quorum?
Yes, I was counting them up. I think we're about one short, so, but I will let you know the minute we have a quorum.
Hey, this is Alan on the phone. I'm not sure if I make the one that is you're waiting for as far as quorum goes.
You're the one, Alan. We've been waiting for you this whole time. No,
Oh, man. Isn't it great? Now you can get started.
Jennifer, do you have a question?
And Jesse, so we have had a few more along with Adam, Alan join, so you can get started. Thank you so much.
Great, welcome. Okay, thank you so much. Welcome everybody to the October Medicaid Advisory Committee. I hope everybody's doing well. We're gonna start with just the approval of the August minutes. Hopefully everybody's had a chance to look those over. And I'll take a motion to approve them when somebody is ready.
Jesse, this is Michael. I would like to make a motion to approve the minutes as written.
Great, thank you, Michael.
Hey, Jesse, it's Joey. I will second that motion.
Great, thank you. All right, the minutes are approved. I also just want to make an announcement about that we are meeting virtually. I made the decision as chair, along with the executive committee, to continue to hold these meetings virtually until further notice due to the public health emergency and for everyone's safety. So if you have any questions about that, feel free to reach out to me. Okay. And last in my kind of notices of one thing I just want to let everybody know is that we have an opening on the MCAC, and this would be for the home and community-based services, or a home health position. So per our updated bylaws, we are now alternating on the MCAC between long-term services and supports and HCBS, or home health providers. So this is the term now. Pete has termed off the MCAC, and we really appreciate all of his time and service on the MCAC. And the new term is now for the home health providers, or representation from the home health provider community. So if you have any nominees, please send them to Sharon, and we hope to fill that seat very soon. And yeah, please feel free to get the word out, everybody, about that. We also want to make sure that that everybody is aware of the MCAC, and that people have the opportunity to join the board. Great. All right. Sharon, would you mind just putting your email in the, I'm sure everybody has it, but put your email into the chat just in case people do want to make nominations so they know they send them to you. Is that right?
Yes, that is correct. They can send them to me. My email is down at the bottom of the agenda, but I will also put it in the chat as well. So yeah,
Kind of hard to
absolutely.
get into this meeting without your email, but still, thanks. Awesome. All right, great. Moving on to committee member updates. This is time on the agenda, standing time on the agenda for committee member updates, things that are on your mind, concerns, questions. It's really an open forum. I'll just create a moment if anybody would like to say anything. And then I can also give a quick update about the communications or notices committee.
Hey, Jesse.
Yes.
This is Alan. I was just curious, and I'm not sure if the answer is that there is no funding or if there actually is something along these lines. But we were having a conversation the other day about homelessness, and I wondered if there were any updates or any funding opportunities that are out there through Medicaid and the ARPA funding for addressing some of the challenges of homelessness. And I just wondered if anybody had an update, or Jesse, if you have an update on that.
So, Jesse, this is Emma. Maybe I can just provide a little bit of update, and then if Tanya's on the line, maybe just to address the ARPA funds. So just so you know, as part of our Medicaid expansion efforts to begin with, when we submitted our 1115 waiver to actually create Medicaid expansion, we also included services around homelessness, right? I mean, Medicaid funding can't be used for the purpose of really like paying for rent or those kinds of things, but we did make a request to be able to provide some supported living services, case management services, tenancy services like helping people apply for housing, working with people to help keep them in housing, right? Because oftentimes it's, just a matter of making sure that they're getting the rent paid on time, that they're keeping good relationships with their neighbors, that type of thing. And so we made that request, that amendment request, when we submitted the original request for Medicaid expansion. We are getting some very, I think, positive news back from CMS at this point, and we're feeling like they're pretty close to approving that amendment. So that will help us at least provide those services. And then Tanya, on the ARPA funds, I know we had attempted to try to address some of that with portion of ARPA that allows a 10% increase in federal funds specific to Medicaid.
Yeah, so Emma, I would just add that our related to the ARPA funding, related to home and community-based services, the state had a requirement to submit its what they call a spending plan. And within that spending plan, we did include support for housing related services for individuals enrolled in home and community-based waiver programs is one of the things that we sought CMS approval of. And we are still, I think we're getting closer to getting approval from CMS on those things, but it would include the same types of things that Emma just kind of ticked off in terms of helping people with applying for housing vouchers, but also applying for just applications to rent a particular unit. It would also include things like helping individuals to pay like a one-time deposit, or if they needed some kind of supplies or furnishings that would help them to have kind of some stability in a new housing unit if they didn't already have those things. So we are still awaiting CMS approval on that.
That's great. Thank you.
Thanks, Alan. Thanks for that question. Stephanie, I see your hands raised.
Yeah, Tanya, what providers is that for that can do those services? Is that like yeah, is there a provider group that specifically has to do that kind of service?
Yeah, Stephanie, it would have to be a provider that is an enrolled home and community-based waiver provider. So a couple of examples, we actually have this, some of these provisions in our New Choices waiver right now. So for example, currently in the New Choices waiver, if somebody needed, let's say, a mattress as they were moving out of a nursing home and into an apartment, Medicaid funding could be used to make a one-time purchase such as that. And we have an arrangement through a fiscal intermediary, a financial management services entity that helps to make those purchases. And then the enrolled case management agencies, in this example, in the New Choices waiver, help to work with the person to identify what their needs are. And then they work with the individual family and the financial intermediary to make a purchase such as that. And then also the case management agent, the case manager could help the person. It's permissible within their case management definition to do some of those housing related, like housing searches and those kinds of things as well.
Hey, Tanya, this is Sheila Young with Molina. I have a question on this, on the fiscal intermediary. Is there also going to be an option for people to be self-directed, whereby the fiscal intermediary would be the one that would pay the caregiver, you know, almost like the person employs the caregiver, that they are the employer, and then the fiscal intermediary pays them directly?
Yeah, Sheila, we have self-directed services in every one of our waivers right now. So if an individual wants to hire, say, a neighbor or a cousin or something like that to help provide personal care, and they're enrolled in one of the home and community-based waiver programs, we have a mechanism to support that. And it's exactly what you described. They work through what we call a financial management services agent. They submit their timesheets. And the agent pays, their payroll taxes and other things, and then pays the caregiver directly.
Okay, great. Thank you.
Mm-hmm.
Right. Are there any other committee member updates? Questions? Okay, great. Well, I just have one thing to mention, and then I'll mention the communications or the notices committee. If anyone, I don't know if you're going to mention this in your director's report about the waiver that's pending the CMS right now, but today is the last day to submit federal comments on the on Utah's waiver renewal application. But I just learned recently that the portal is having problems on CMS. So I got just a few people emailed me that they were trying to submit comments and having trouble. So if you have had trouble, you're not alone. It looks like they're working to fix that problem. And if you haven't submitted federal comments yet, sounds like you should be able to do so soon. So just an update if anybody's a procrastinator like me when it comes to submitting comments. And the other thing I just want to mention is the notices committee. This is the small committee of folks reviewing and talking about Medicaid notices and potential ways to make them clearer and more accessible to members. I just want to say thank you so much to Jeff and Maurice and for being, and for DWS and DOH for being part of these committee members. I guess you're there to give the update, but I just really appreciate you all being there. And I think we're just making great progress as a group. So if you have any updates you want to give, but thank you all. They've been really generative conversations.
So I guess maybe, Jesse, if I could just chime in for a second. This is Jeff Nelson. In our most recent meeting, we actually had an opportunity. So our hope over time is that we can get some more community feedback on notices as they're developed and get that real time. And that's been our kind of stated goal at the very beginning of this. we actually had that experience as we had a notice that we had turned off in our system, thinking we did not need that, only to realize that that notice generated all the information we needed for the unwinding to occur, to get us the data that we're looking for, and had a unique opportunity to get some real time. It was actually live feedback on that particular notice. And so it was very helpful to have you guys there to discuss that. So we welcomed your feedback, and hopefully we end up getting a better product because of that. So thank you for being willing to participate.
Marissa, is there anything else you want to say?
No, I'm actually glad I'm part of that process. This doesn't work without advocates and your guys' feedback. So I think it was a good experience, and I look forward to the continuation of that.
Great. Yeah, me too. And just an announcement, we have a nifty spreadsheet that you all have created to keep track of existing notices. So if anybody has an existing notice that they feel like could use some improvement or have questions about, reach out to me. We can add it to the spreadsheet, and it's a way to kind of keep track of notices that aren't new, that are existing notices but still could use improvement. And we have a list going there, and we'll start kind of going through those as a committee as well. Great. All right. Well, thanks everybody. And Brian, I'll turn it over to you for the interoperability report.
Great, thank you. My name is Brian Roach. I am with Medicaid. Let me share my screen real quick. All right, thank you. So I will be going through a demonstration of a new addition to our website. This is an online provider directory. The purpose of this demonstration is to make committee members aware of this new tool. And also we want to use you to help us get the word out in the future to providers and members. So this is the new provider directory tool, but I'll back up a little bit and show you how it is found on our website. So from the main page, this is medicaid.utah.gov. There are a few different ways I'll demonstrate. So first of all, a member could go to this member subpage. Right here, there's a find a healthcare provider button. So that's one way of getting to it. I'll back up again, demonstrate another way of getting to this. So an individual could click on the healthcare providers and then right over here, there's a find a healthcare provider link. It's another way of getting to it. There are a couple other ways, but our first effort is to get the notice out to providers. And then the second phase of this is to really drive out the word for our members. And I'll dive into that a little bit more later. So there are a few different ways to search for providers: by name or by specialty and address, city zip code, and a distance filtering, along with when you type in a city or a zip code, you can use that distance filtering. On the providers, we are including right now physicians, nurse practitioners, physician assistants, dentists, oral surgeons, physical and occupational therapists, with more to be added later. On the facility tab, we have the ability right now to search for eyewear and medical suppliers, pharmacies, home health agencies, and personal care agencies. Again, more to be added later. A big obstacle for us all to overcome is the quality of data. And as I demonstrate more of this, that is one purpose of this demonstration, and another, we're putting out a MIB article to get providers more aware of their own data in this, and the quality of the tool is just going to be reliant on the quality of the data. So You may see that as I demonstrate the tool. So I've pre-populated a few searches. First one is just a demonstration. I've searched for OBGYNs in St. George. On the left-hand side, there is the ability to filter by gender, for example, filter by language spoken, although it is possible if you filter down too far, you may not find exactly a provider meeting the combination that you're looking for. You can see many providers, there are not currently hours of operation filled in by the provider. So that is another reminder. Up here, we are giving special instructions to please update your information. If you search for yourself and you notice any inconsistencies or missing data, there's a link right here to fill that in our PRISM provider enrollment system. Another demonstration, so I have searched for dentists in Logan. There's a demonstration of that. Over here, I searched for eyewear suppliers in Tooele. And over here, I looked for home health agencies in Price. This gives a little, so I tried to hit different corners of the state, but this gives some high-level overview of what it's capable of, and I would encourage everyone to search for themselves. Just another disclaimer we put right here, if you're enrolled in an unaccountable care organization or other health plan, like an integrated plan, you may want to speak to them about providers on their network, and most of them already have directories. And then also, our HBRs continue to be available. They have been available and continue to be available to help a member find a provider. And a couple other notes. So this is also available in Spanish. So we have made the translation on our side for each of the specialties and counties and all of those items. Then also, I mean, beyond Spanish, there are a lot of built-in browser functionalities to do more translation. So we understand that English and Spanish may not be the only languages, of course, but further translation is pretty often supported within a browser functionality. So beyond this, our next steps would be, like I said, we're putting out a MIB article this month to get the word out to providers, encourage them to update their information. Next month, we'll start focusing on some of the member outreach and communication, getting them aware of it, including putting links on our website to on some of the member-facing portions of our website to make them more aware of it. So with that, I will turn the time back, and I'm available for any questions.
Brian, can you just say, I guess, what interoperability is? I think it's a term that we're hearing a lot of, and so yeah, just how that would be helpful, maybe.
Yeah, sure. So this particular item came out of, it actually came out of the 21st Century Cures Act that required it. That, since that time, there have been further requirements through the interoperability and patient access rule that was signed into law March of 2020, I believe. So an additional thing that requires is making all of this information available through an API, which is an application programming interface. So potentially individuals would be able to use a smartphone that is able to interface with our data and use it in an app of their choice. And then there are some additional requirements under that interoperability rule. around patient access to data and further data sharing with CMS.
Thanks.
Mhm.
Stephanie, you have your hand raised?
Yes. Thank you, Brian. This is awesome, and I know a lot of members will benefit from this. I couldn't tell earlier whenever you were scrolling, but something that I get asked by people that I know on Medicaid often is like, especially I guess maybe for people that aren't in the plans, or I don't know. People ask about the mental health stuff a lot, like how to find mental health provider, and I don't know if this is going to help with that or if it will be different because of the local mental health authorities and all of that, but I just thought I'd ask.
So, I mean, certainly mental health plans can assist in finding a provider, and most of them do have provider directories on their own website. Emma, would you like to add something?
Yeah.
on
I was going to say, if all else fails, Stephanie, the best thing to do is to encourage the member to call a health program representative, because what they'll also do is involve our behavioral health team, who can reach out, and they do this now. I mean, they'll reach out to the prepaid mental health plan and work with the plan directly to say, okay, this person needs a provider, or they're not happy with their existing provider and want to find somebody else. And I think it's going to depend too on what Medicaid program they're in, because for instance, the targeted adult Medicaid group, they're all fee for service. So they're going to need some additional assistance. I mean, it may be the local mental health authority that's best suited to provide services, but there are a lot of other providers as well. And again, if they're a Medicaid expansion, on the Medicaid expansion program, they might be in an integrated plan. So the HPR can assist the individual to say, well, let's get a hold of, Select Health or Molina or Healthy or Health Choice, or let me help walk you through their provider directory. I think our goal long-term is when PRISM comes up, there will be a similar tool, or this tool essentially, that will also indicate where the provider is actually enrolled. So do they take fee for service, and which plans that they're enrolled with as well. So that will be even more information that'll be on the tool. But I just really encourage folks to encourage people to call the health program representatives, because that's what they're not only there to help people enroll in managed care, but they're also there just generally to help our constituents.
Thank you. That's helpful. Thanks for that. And thanks for doing this. I know this will help a lot of people, especially in rural communities that have a hard time finding providers. So good work, everyone.
Thank you.
Brian, I apologize if you already said this, but in terms of like the updating piece, how does this get updated?
So in terms of like if a provider updates their records, how quickly is it shown here? Is that the question?
Yeah, I guess so.
And that would be nearly instantaneous. I think next day, actually. So not instantaneous, but next day. And then the other question, were you asking about like how often will we increase? Like there are further specialties to add to this piece, and so that is another update that we need to do on this end. And so we're going through the data quality of those other specialties to do some initial screening, but more to come. Would definitely within 1 to 2 months, we'll continue adding providers.
Great, thank you. Thanks so much.
Mm-hmm.
Great. All right, any other questions? All right, thanks so much, Brian. And I'll turn the time over to Eric, I believe. Yep, Eric with the Medicaid budget report.
Sure, for everybody's most anticipated piece of this whole presentation, I'm sure. Sharon, would you mind if I present? Great, thank you. Let me just pull this up. So I'm going to give a brief report on where we closed out state fiscal year 2021. It's just taking a moment to get my screen up. I apologize for the delay. So we'll start with our administrative line item, which covers the administration for the Medicaid program, and then also the pieces of Medicaid that are administered by DHS and DWS. Just kind of a brief overview on each category. So fixed funding are the direct appropriations from the legislature in general fund and expansion fund. Revenues are where we receive transfers from other state agencies or from other non-state government-owned entities to help fund the program. Expenditures, hopefully, are fairly self-explanatory. Lapsing is where money either lapses back to the general fund or expansion fund, or it's where the legislature gave us authority that we didn't need to use. So the lapsing can kind of be a misnomer. It's not always money that is lapsing back, but sometimes it is. And then finally, non-lapsing, and this is money that they allow us to keep in our budget. So for state fiscal year 2021, because of the maintenance of effort from the Family First Coronavirus Response Act, the legislature has allowed us to non-lapse as much money as possible in order to see what happens with the maintenance of effort and give us time to deal with those changes. So this is where our administration line closed. We had 142 million in expenditures and we non-lapsed 3.4 million. So the next line, this is the medicated services line item, which is where the bulk of the expenses are. And the same categories exist here. And as you can see, our expenditures were 3.7, close to 3.8 billion. We non-lapsed 17.9 million. And majority of this, actually not even the majority, almost all of this lapsing fund was lapsing back authority. So it's not actually real dollars going back. The next line item is the Children's Health Insurance Program line item. And here we had 125.3 million in expenditures and non-lapsed 2.3 million. And finally, this is one I know everybody has a lot of questions on, which is the Medicaid Expansion Fund. And so for this, we're just keeping track of what we brought in through the tax and also through legislative appropriations, and then what was spent, and then what the remaining balance is. And this is a running balance. So each year it accumulates if there's additional funding at the end of the year. Now, one question people might ask is, why did the expenditures go down from 2020 to 2021 in the expansion fund? And I can explain that fairly simply. We've come up with a much better way to allocate pharmacy rebates between the Medicaid services line item and the expansion fund. And so that's a reflection of more properly allocating pharmacy rebates to the expansion program. So any questions so far before I go on to the last slide? Oh, Michael, yes, I figured you might have a question.
Yes, I do. Thank you. All right. So as we were looking at this fund for the information presented to the legislature last November, I think the forecast was that the balance was going to be somewhere around $80 to $90 million at the end of fiscal year 21. So I guess, as I recall, the revenues were estimated about $110 million. So we exceeded our revenue projections substantially, but the expenditures are quite a bit lower than would have been projected. So can you kind of speak to that? Because presumably the enrollment in Medicaid expansion has been a lot higher than many would have guessed given the maintenance of effort. So you'd kind of spoken about the pharmacy expenditures. I'm guessing that's offsetting some of these expenditures a little bit.
Yep, that definitely is. Another phenomenon we've noticed in there is kind of a pent-up demand phenomenon, especially in the TAM population. We've noticed that their per member per month costs have been dropping year over year. And it seems like there was a higher initial need, but now that we're deeper into the program and they've met that initial pent-up demand, their costs are looking less than we would have anticipated.
Okay. Very interesting. So now we have $158.9 million as of the end of fiscal year 2021, and that includes $56 million being taken out of fiscal year 20 and 21. And then that's scheduled to come out of the current fiscal year as well. So, oh yeah, the other question I had was, what about the expansion fund contracts? It seems like all of the health plans were expecting to have expenditures outside of their risk corridors on the contracts. How did you account for that? Did you book a payable for the expansion fund, or is that just going to come out of the fiscal year 2022 balance?
No, that's a good point. We did book payables for those risk corridor settlements, but they were just booked in general. So I don't know that it was anticipated that it would hit against the expansion fund, but that's a very interesting point that we'll probably have to look at, because you're right, the majority of those payouts would definitely come from the expansion fund. So
okay, so with the revision, that could possibly drop the balance a little bit.
Yes, most definitely it will. Thank you for that clarification, Michael. We will take that into consideration.
Okay. All right, well, I guess we're in a lot better position than when we thought, where we thought we would be as of last year about this time. So that is good news. Thank you.
And I see.
Can you?
Too.
Sorry,
okay.
I know. Can you explain that last part of the conversation, like starting with Michael's question and your response, Eric? That didn't make sense to me, and I'm sorry, I couldn't Google all the words in time.
No, it's okay. So in our contracts with our integrated healthcare plans, we have a risk corridor for these first few years, which basically they have a medical loss ratio that they have to be within a certain range. And if they're below a certain range, they need to pay us back. And if they're above a certain range, they're above a certain range, they need to pay us back. If they're below a certain range, we need to pay them. And so because those programs relate to the expansion, we've booked a payable, meaning we are anticipating have to pay out additional dollars to those plans. And so we've put that on the state's books saying we're going to have to pay that out. But as Michael so clearly pointed out, those funds would have to come from the expansion fund, not the state general fund. And so we're going to have to make an adjustment there and make sure that those payables we've booked will be hit against the expansion fund rather than the general fund.
Okay, thank you. So does that mean then that like the new enrollees were in like their care, they needed more care than originally predicted, or am I understanding that correctly?
Yeah. Sorry, Emma, go ahead.
So Stephanie, because we didn't really know when we implemented Medicaid expansion, we didn't have a good sense, excuse me, of what their costs were really going to be. To the point that Eric made, that we knew that there was going to be some pent-up demand. The plans were concerned about the level of risk because we did establish rates for these groups, but still we didn't really have a lot of historical information on their utilization. So we agreed to say, okay, we're going to establish these rates, but then we're going to have a risk corridor. So we're not asking the plans for this population for, really it's going to end up being about 3 years to assume all of the risk for this population when they're new to all of it. So it's not only our integrated plans, but it's our accountable care organization contracts that also have expansion members where they're not integrated. And it's also our prepaid mental health plans, because we had no idea what their utilization of services would be. So that's what they're referring to, is it's looking like in some cases, some of the plans are going to actually have to pay the state back. And in other cases, we're going to have to pay the plans some significant money to basically cover some of that risk that they
Okay. That's helpful. And do we think that also might be that Medicaid members are, do we think it's related to like COVID hospitalization data or no?
No, I mean, I don't think specifically. As I said, we knew that when we added the Medicaid expansion population, this was a group that previously didn't have a lot of access to health care. And,
Gotcha.
we knew that because a number of them, were homeless or had, like I said, just frankly did not have access to good health care, that they had chronic medical conditions that had not been addressed. We knew a lot of them had mental health and substance use disorders. that hadn't really been addressed, but we just didn't know how much utilization they really were going to have. So again, until we could gather all that data, we just didn't want to put the plans in an unfair position. And so that's why we created risk corridors for a couple years of our managed care contract just for this population. Going forward now, we will feel like we have enough utilization data that we'll just turn them into full risk contracts at some point.
Okay, that makes a lot of sense. Thank you for explaining. Sorry if everybody else.
No, you're fine. No, that's fine.
Thank you.
Thanks. Michael, did you have a comment?
Well, actually, I had a question, but I do have a comment on that too. I think the risk corridor actually protects the state too, because if the rates had been set too high, there would have been big windfalls that the health plans would have got. So it really is an effort trying to baseline accurately the expenditures for the ACOs. But to the question I was having, Eric, back to the pharmacy rebates, did you go back and restate prior year's expenditures for the expansion fund and make adjustments with general fund, or just fiscal year 21 is the first time the rebates have been more accurately accounted for, and that will be the process going forward?
Just fiscal year 21.
Okay. All right. Thank you. All right. And then if there aren't any other questions by others on the expansion fund, I want to go back to the base Medicaid budget as well.
Before we do that, could I just ask you to clarify the pharmacy rebate? Just give a little bit more information about that too. I think I got confused. So why are we going back, and what are we doing differently?
So basically, we receive rebates from pharmaceutical manufacturers on products that are used by Medicaid clients. We get those in bulk, and so we have to allocate those rebates across how much goes back to the Medicaid line and how much goes back to the expansion fund. And so we just have a better basis for making that allocation than we did in the past.
Okay, I see. Great, thanks. Okay, go for it.
Okay, so on the Medicaid service line item, you're saying your lapsing budget was $79 million that went into the Medicaid restricted account, or where did that lapse to?
No, that is all authority being lapsed. So as you recall, like with the assessments, they will give us appropriations for those expendable special revenue accounts. And if we don't have expenditures that justify that spend, we have to lapse back that authority. So it's really authority that's lapsing back, not actual dollars.
Okay, so that's just an accounting thing for everybody else watching online here. But the non-lapsing then, the 17.9, that ends up going into the Medicaid restricted account.
No, it non-lapse, so it's remaining in the Medicaid budget.
You're keeping that. So how much gets put into the Medicaid restricted account as of this fiscal 21 closeout?
So nothing would have. So basically, the only thing we lapsed was authority, and all non-lapsing remained in the Medicaid budget.
Okay, so this gets to the head of, I think, the question for many of us. Since January of 2020, the federal government has given the state enhanced federal match of 6.2% federal funds on the legacy population, not affecting the expansion population. And on a roughly quarterly basis, what is that amount?
So Michael, I'm glad you asked. That was the next slide. So I paused before we got in here to ask any questions. So here you go. So this is what this looks like. So for quarters 3 and 4 in state fiscal year 2020, that is just the number divided in half, because we basically weren't able to draw those funds that enhanced 6.2% until quarter 4. So really the number posted in quarter four was about 87 million. And so I've just divided it up to make it look more uniform between 2020 quarter 3 and 2020 quarter 4. But as you can see, it's about in the neighborhood of 45 million, depending on which quarter.
Okay, so if the state has received a windfall to the tune of roughly $45 million per quarter, which is around $180 million per fiscal year, where's the money gone? Because I think we recognize some of the money has stayed with the program because of the maintenance of effort, requiring additional people to stay on the program. But how much has been transferred to other parts of state government, or has it just remained within your Medicaid services line item along the lines of your lapsing authority to cover all necessary expenditures, and how's that eventually going to be reconciled?
Sure. So I think the easiest way to look at that is to look at the fixed funding between 2020 and 2021. And you can see that we had a reduction in our appropriations there. So that would have been money that would have moved to other areas of state government. And then you can also see that our expenditures went from 3.3 to 3.7, or not 3. Yeah, sorry. That's in billions, 3.7 billion. So you can see there's about 400 million more in expenses with less general fund to support that. So that is a direct result of the MOE and the biggest contributor to where most of this funding went.
Okay, can you go back to that previous slide, please?
You bet.
Because fiscal year 20 arguably would have had at least 1/4 of increased enrollment. And you were already dealing with Medicaid expansion starting January of 2020. So there were some newly eligible adults coming into the program to begin with, but that already reflects a pretty substantial change from 19 to 20, and then 20 to 21 is definitely a big expenditure and revenues. So your general fund, so you say fixed funding, your terminology is glossed over for the masses, but in terms of
it is.
When you say fixed funding, is that your general fund appropriation, or
So it would
state
be,
and federal funds?
no, federal funds would be in the revenues. And you can see just by the magnitude of that's where the federal funds would definitely fall in. So the fixed funding would be the general fund appropriations, expansion fund appropriations. So any of those items, or restricted fund appropriations that come from the legislature.
All right, so all state funds, regardless of source, are coming in your fixed funding.
Ish. So transfers and expendable receipts would come under revenues.
Okay, with offsets for dedicated credits and all the other fund that will.
They call those.
Asking some additional questions on here shortly.
Say they call those expendable receipts now. So they're not dedicated credits anymore.
I'm stuck in 2015 state government terminology. Sorry, I'm not remaining.
You're fine.
Okay, so your cut, you're basically saying they took roughly $22 million out of your fixed funding from 2020 to 2021, but you had, for that same period, $180 million of increased federal funding. So that still seems like a pretty big difference, even if you account for like $450 million of additional expenditures.
So I'm missing the 180 million in federal funding, but.
Well, so if you're saving $45 million a quarter, and we have 4 quarters.
Mm-hmm.
So 4 times 45 is 180. Okay, just wanted to check my math since
No, that's good. I just wondered where you derived that number from, that's all.
Okay, so $180 million of savings to the state, roughly, because you're presumably making comparable expenditures with better federal participation for a lot of these expenditures, but you're spending more money on people who otherwise wouldn't be enrolled in the program. So I'm just trying to get a sense of net gain of $180 million.
So,
and then maybe net increase in expenditures like you're talking about here, the 3.7 to 3.3, even if you assumed a flat baseline with no Medicaid expansion dynamic, which may not be a great assumption. That's going to be $450 million of additional expenditures there. So
right,
that offsets 1/4. No, 450.
No,
180. Plus you got the revenues. Okay.
Yeah. So, I mean, you'd have to remove the
All
non-lapsing.
the federal funds too.
Yeah, you'd have to remove the non-lapsing out of there. And then so about 160 something and change versus 450. That's pretty close to the match rate.
Yeah. And then trying to pull out the people who are expansion related where you're not getting the enhanced match.
Yep.
So roughly then, if I'm not going to ask for the exact figure, if you had an increase of Medicaid expenditure, or Medicaid federal match of $180 million, roughly what percent of that do you think is being spent on new enrollees that otherwise the state wouldn't have been spending money on?
See, and that's a hard question because when we look at the enrollment numbers, particularly in the expansion categories, because expansion was new, we had our projection models for how quickly enrollment was going to ramp up in those programs. And oddly enough, despite the COVID pandemic, those numbers haven't deviated too far from our projections. So we don't really have a good methodology for teasing out how many of those people are due to the maintenance of effort versus how many are due to just the normal ramping up of Medicaid expansion. And so,
all right, so even not trying to control for your historical projections, just in terms of what you're spending now versus the $180 million additional fund, that's how much differential? Even assuming none of it is a maintenance of effort requirement that all the people would have stayed on the program, would have been eligible for and enrolled in the program as projected or as experienced.
So I'm sorry, I'm not following your question. I'm sorry.
Okay, so let's just pretend there was no maintenance of effort and
Okay.
everything you've experienced for caseload and expenditures would have been normal.
Mm-hmm.
Then the additional federal funds of $180 million per fiscal year, is that enough to cover everything you're experiencing?
So
in
without,
terms of the difference.
yeah, without this, it should have been, because if all the growth were in expansion, so that's just one category that we've seen growth. We've also seen significant growth in children. And so again, hard to tease those out because of the same factors with expansion. We don't have a good methodology to say for which of these kids are on because of maintenance of effort or not.
So I think the concern, I think, going forward, when you consider the last count I heard was our caseload has grown by 146,000 individuals, right? And at least close to 80% of those individuals will be in capitated plans. So we're paying a capitation for them, whether they're utilizing any services or not. I think the concern, and maybe Michael, I'm missing where you're going here, but we know that some number of these 146,000 individuals are going to stay on, and the 6.2% is going to go away. And I think there is going to be a gap in terms of funding there that we're going to have to address in the future. It's probably not in 23, it's probably going to be in 24, more so. It depends when the 6.2% goes away. But that is, like Eric said, unknown until we go through the unwinding. How many of them are going to continue to stay Medicaid eligible?
Yeah, so I guess there is that question of what is it going to look like in the future, and you'll have to work through that with your forecasting and consensus calculations. But I'm just trying to get a sense, aside from all the detailed calculations, of how much has the state benefited, net or lost, because of this maintenance of effort and the enhanced federal match. And you're saying you've been able to reduce your state fixed funding from fiscal year 20 to 21 from $715 million to 693. So that seems like that's roughly a $21 to $22 million a year, well, fiscal year over year savings to the general fund appropriations, and your expenditures have gone up substantially. So at a minimum, and then you have the lapsing. I'm not sure how to interpret your 92 to 79. It looks like, has the $92.3 million lapsing from 2020 been incorporated into the 2021 lapsing figure?
No, and that's going to be hard to do that comparison, and here's why. Because in 2020, we didn't have full carry forward authority, so part of that lapsing funds would have been actual money lapsing back to the Medicaid restricted account. So it's not really a comparable number to compare the 92 to the 79 because we were operating under a different set of rules.
Okay. So if I were to go out on a limb and make a non-insightful statement based on all the data you have, it would seem like as we move from fiscal year 2020 to 2021, the appropriations process seemed to feel comfortable that you were saving at least $20 million as you left from fiscal year 20 into 21 of the 180 million that we were going to anticipate. So they said, we'll take $20 million of that and we can put it back into the Medicaid program for other purposes or move it to other parts of state government. And then we're going to leave the rest with the Medicaid budget. And then if you have leftover money, we'll give you carry forward authority so you can keep spending it going forward. And then when it's all done, we'll sort through it. But there's some cushion in there in your budgeting for when the public health emergency ends and you have the 12-month run out on the redeterminations, that arguably there is some cushion built into the budget to help carry some of this population into fiscal periods where you won't have the 6.2% enhanced federal match. Is that a generally fair statement?
So we have the 17.9 and we're going to have that discussion in consensus. So right now we have the 17.9.
And I do think that's fair to say, Michael, but one of the other things that we've talked about to the LFA, well, more so to GOPD, is that we need to do some modeling in terms of, you know, when we think that the PHE is going to end and how quickly workforce services can get through the review of cases and how many people will fall off. So yes, there's a little bit of cushion. I don't know, it's very unlikely it's enough.
Yeah.
You know?
So you've got the non-lapsing that you've kept in your budget, the 17.9, and that may be added to or taken away from as you go through consensus. But I guess the 79.5 million in lapsing, you're just saying you have that in spending authority for these other accounts, and that really doesn't play into this discussion at all as it is carrying forward here.
That's correct.
All right, so more to come, but basically the state, if we were going to say very roughly, from fiscal 20 to 21, the state saved the difference between your fixed funding amounts of 15.2 to 693.6. That $20 million was roughly savings that was able to be redirected into other parts of state government or the Medicaid program. And then you're loosely trying to cover the maintenance of effort with the remaining funds and have $18 million left over, assuming everything else was perfectly budgeted. So between those two, I would say about $40 million, assuming you had no cushion in your budget from 20 into 21, assuming you were spot on, because you had $2.1 million of non-lapsing as you closed out 20. Roughly 40 of the $180 million has been saved between fiscal year 2020 and 21, whether it was by reduced appropriations in your fixed funding category, and maybe the 17.9 should be offset by the 2.1, so maybe another 15 million or so.
I'll just interject that part of that non-lapsing in this budget is the PRISM funding.
Okay. So additional complications with that. But roughly $30 to $35 million is a reasonable estimate of what the state has experienced in that $180 million, a lot of it is actually being spent on the maintenance of effort, realistically.
Yeah.
Or at least more than half would be a reasonable estimate.
Yes.
Okay. All right. Thank you for the detailed work through that. And I'm sure I've bored most of the committee and the observing public, so I will retreat on my questions and appreciate the explanation.
I just took 2 extra strength Excedrin just to give me a caffeine boost, Michael. So
you're ready for another 15 minutes? Is that what you're suggesting, Brian? Let's keep going.
No, hey, no. I actually I just wanted to interject that this is really important stuff, though, because if it has been redirected to other parts of state government, I mean, it's really important to know and understand that. Just going forward as we look at the program.
I think to that point, that's a good point, Brian, that as we're having conversations with different people in the legislature, there are different perceptions by some legislators. It's been brought to our attention that the provider community has got this giant windfall of additional payments as a result of this enhanced federal match. And I think that's just one of the things we're trying to get a handle on. It's related to caseload and people actually getting services, but there haven't been any increases in rates, and just trying to be in a position to speak on the same level with the department in terms of how those funds may have been used or redirected even to other parts of state government or into other parts of the Medicaid program. So again, thank you. And I appreciate Brian's points there.
And that's very interesting, Michael, because we have not heard that from decision makers. So yeah, I think we can absolutely say it did not go to any sort of increased rates.
Yeah.
It's just dealing with caseload growth that's caused by the MOE for the most part.
Yeah. And as is frequently the case, I mean, the conflating of 6.2% extra Medicaid match with CARES Act funding, ARPA funding, money the state got through the CARES Act, and trying to keep all of those funding streams clear and straight can be confusing. So we just want to make sure we understand that. So thank you.
So I know, Stephanie, sorry, I see your hand raised, but I know Jesse asked a question in the chat as to what changed between on the lapsing authority. And so that came through intent language.
Is that just for Medicaid, or was that for all?
Just for Medicaid. And it was strictly due to the MOE and their understanding of when we did the consensus process on the MOE, we really didn't have a good basis because we've seen growth in the program that's unprecedented, and none of our financial models or our forecasting models could have predicted it. And so just with the uncertainty, they said, we will give you authority to lapse any funding that remains.
I see. Okay, thanks.
Sorry. Just so I can understand something, so I'm trying to piece together a couple of things that between stuff said. I'm sorry for the background noise. There's a lot of construction where I live anyway. But so I'm just confused because Emma said that there's a lot of people who we might not know, like they're just staying on, but we don't know what their utilization rates are. But then, and so the capitated payments we're paying, but if they're not utilizing a lot of care, then it's like we don't really, I'm just trying to understand, like, I get that there wasn't a rate increase, but like if there are a lot of just those capitated payments that are being paid, to the point about the risk corridor earlier, like how do we know, like what's the information about whether or not there is like overpayments or underpayments based off of like the utilization patterns of all of these people that are staying on? Does that make sense? Like, I'm just trying to understand.
Sure. You're getting into really deep territory, but it's good. So earlier I'd mentioned an MLR, or the medical loss ratio, which is a calculation that's done to show how much of the money that was paid to a managed care plan actually went for services. And so that medical loss ratio is the basis for the risk corridor settlement. Does that make sense?
I think so, yes.
Okay. All right.
We're looking at actual costs that the plans have incurred, right? So, and that's a reflection of the actual utilization.
Gotcha. So we do know that, but to your point, Emma, then I'm just trying to integrate that with the point that you made about how we don't know, like the capitated payments that we're paying, we don't, like, even though the state's paying those out, if a lot of those patients didn't utilize a lot of care because of, for whatever reason, during the last 18 months. I mean, I guess I'm just, like, I hear what Michael is saying. I'm just also trying to understand, like, if the suggestion is, I just don't want it to, I don't want it to ever look like industry is like the victims here, and when really, like, the legislature is going to fight the people, right? So I'm just trying to understand, like, from a member perspective, like, I just don't want it to, like, seem like, I don't know. I just, if there's extra resources that, like, the industry has from the last from whether it's seen that they benefited or not, it's not just about a rate increase. Isn't it also about whether we were paying out a lot of money that they didn't have to then turn around and cover care? Do you know what I'm saying? I'm just trying to understand that.
No, I think what Eric referred to, the medical loss ratio reports, which by the way are required by CMS as part of the managed care regulation. I think that is kind of the assumption that many people make, and frankly, I think it was a concern that we had too over the course of managed care for many years, is that it needs to be a reasonable rate so that plans can reasonably cover risk. They also have reasonable costs of doing business, and at the end of the day, they do minimize the risk to the state and overall save money. But these MLR reports basically indicate that a lot of our plans, most of our plans, are bearing more risk than they probably should at this point, based on their actual expenditures and the revenue that they're taking in from capitation payments. So I think those reports have been pretty revealing. And Michael, do you want to go ahead?
Yeah, I think just thinking back to the conversation, and Stephanie is tying the two things together, because Emma, you had made a comment that because people are enrolled in capitated plans, the state is making a payment every month, whether they're using services or not. So I think there's that statement, which may have left Stephanie with the perception that, okay, we don't really know what we're getting with the capitated enrollment. And then there's been the separate conversation about the MLR and where the health plans are, the points you were just making. So I think just trying to tie it together, and hopefully this will be helpful for Stephanie, is while a large percentage of the expansion population has been enrolled in a capitated arrangement, as the plans have experienced their enrollment and the expenditures related to those members, they have exceeded what the actuaries who set the rate had expected would be paid out. So there's actually been more money being paid out than the actuaries would have predicted for the expansion population. And that's going to require a settlement in the risk corridors that will take additional money out of the Medicaid expansion fund to settle up those contracts to make sure we get the rates established on a meaningful or an accurate baseline going forward. So hopefully that ties the two pieces together as I've been listening to the conversation.
Thanks, Michael. I think that's helpful. And I think that the problem is we're talking about several different things that are occurring at the same time. The maintenance of effort. Had the maintenance of effort not occurred, we still would have had these risk corridors because of the unknown with this population. And we would still have medical loss ratio reports. So it's just that all these things are coming together at the same time, which makes it a little bit more complex.
All right, any last questions?
I guess I just have one question. This is a little bit off, changing gears a little bit, but looking forward to when the PHE ends, how does this factor into, keeping people on while we go through renewals? Do you feel comfortable where we're at now to be able to move forward and do that in a way that that we can do that we can actually go through all those renewals even after the PHE ends.
Well, we're going to have to go through the renewal.
Right.
I think the question's going to be, not only for us, but for all the states, when does the 6.2% enhanced funding end? Because right now it's written in the law that it ends sooner than the renewals, much sooner than when the renewals will be completed. And so that does mean that all states are going to potentially not have that additional federal funding, while we still have a lot of individuals that were still on the program, and we're still trying to determine whether or not they should stay on the program. And so, that is an issue. As I mentioned earlier, we're going to do some modeling. The National Association of Medicaid Directors is pushing CMS to push decision makers to make an adjustment to that in the federal law, because no one anticipated the PHE lasting this long, or the growth in caseloads to be this high, which now is going to require a lot longer to go through the review process. So I think we are anticipating that there's going to be a funding gap, and how do we address that? And it's going to depend on how the federal government reacts, and just exactly what that amount is for Utah. And just so you know, we've made GOPB aware of this. We've made the governor and the chief of staff aware of this. So now it's just all of us getting out our magic 8 balls to try to figure out where is that tipping point, and then what does that mean?
Okay, that's helpful. Yeah, I was just thinking about, okay, that's helpful. All right. Well, but the good news is, actually, sorry, hold on. Stephanie, I see you have a question in the chat. Okay. So more to come, but I guess one good news is that the expansion still has not exploded, that we have a healthy balance in the account. And will you be sharing those slides, Eric? Sorry, before you.
Certainly, I will send them to Sharon and have her distribute them.
Okay, that's great. But we do have a healthy balance in the Medicaid expansion account. I just wanted to sum up if there's any more alarm bells rung at any future meetings, that's at least one very clear takeaway we can take away from this. Is that accurate?
Yeah, I think we do have more than we expected to have, and now we'll just again have to see how this plays out. And we can, as we get more information, we could just periodically update, the committee and the public in terms of what is going on at the national level, and as we're trying to again model this and try to figure out what is happening. I think there was a comment in the chat earlier. Originally we had anticipated that the public health emergency would end at the end of this calendar year. Now it's extended into the new calendar year. There is some discussion that it may go all the way through 2022. So this may, again, as this continues, we'll just have to see when this issue becomes an issue, I guess. But so that is the challenge. We just don't know, and it's all hinged on when that public health emergency declared by the Secretary of Health and Human Services, when that ends. So we'll just keep you posted along the way. Should we go to the next item, Jesse, on ARPA funds, and I'll also rely on Tanya and Eric to jump in here. So, there have been CARES Act funds and ARPA funds. And when we talk about ARPA funds here, again, we are referring to the specific section in the American Recovery Plan Act that allowed for a 10% increase in federal match to basically support home and community-based services. And when they talk home and community-based services, in this definition, the federal government also included, for the state of Utah, for our purposes, outpatient behavioral health services, as well as similar services that are being provided in a school-based setting. So, so the challenge with all of this is that CMS asked all the states to put together what we refer to as a spending plan, which we did. And largely the biggest chunk of these funds, what we had suggested, because of all of the issues that providers are facing in the community right now, particularly with regards to hiring and retaining staff, and the concerns about the lack of direct care staff, as we said, the biggest part of these funds we would like to provide to providers in the form of supplemental payments to try to help them address that issue. The other complication with CMS is that they have different ways to get the underlying expenditure authority in order to draw down those funds to do this. So we had to submit a spending plan. We got a partial nebulous approval of part of our plan. Continued to work with CMS just to get some clarification. So what we know right now that we have is we do have, I guess, approval of the plan to go ahead and make the supplemental payment part of our proposal. So in addition to supplemental payments to these providers, we had also proposed a couple of other things. We had proposed to continue family caregiver compensation. So again, and I will turn this to Tanya in a minute to give more information, but this is a situation where the state has actually been paying, in the case of home and community-based service waivers, have been allowing families to get compensated to take care of their loved ones in the home who are enrolled in HCBS waivers because, number one, of COVID, and also because of the lack of direct care staff. And a lot of these families were having to stay home to take care of their loved ones and quitting their jobs in order to do that. So we were compensating the family members, help the family member and help the individual who is part of the HCBS waiver as well to be well cared for. So part of our plan was to allow us to continue to pay for those reimbursements. Also, there was an opportunity, or in our plan is an opportunity to have providers submit for grants for different infrastructure type projects that would help support home and community-based services. Now, I'll turn this to Tanya in a moment, but the only piece of our plan that has been approved to some extent is the 5% supplemental payments that we're making to providers. So there's the plan approval, but then CMS, after the plan approval, also requires that we get the underlying authority, another step in the process. It's different for home and community-based waivers than it is for our other state plan services. So Tanya, you do want to explain the Appendix K and the other parts of the plan, and then we'll add a couple of other comments.
Sure, thanks, Emma. So as Emma said, we do have the approval of the home and community-based waiver part of the supplemental payments, and we're still working with CMS to get that approval for the home health and hospice, the behavioral health, and the school-based services, and also autism related services as well. We need that state plan approval in order to move those specific things forward. There was a system that we set up to allow providers to make an attestation that they understood that the 5% supplemental enhanced payments were time limited. They also had to attest that they would use a portion of the funding to address direct care workforce issues within their company, and that they would also use the funds to enhance, expand, or improve the services that they provide. And we opened that up for providers within the last couple of weeks, and we've had a really good response within these first 2 weeks, and have distributed or are in the process of distributing payments to providers who are in some cases really desperate for additional funds to help incentivize workers to stay, to incentivize workers to apply for jobs. So we feel really positive about those 5% supplemental payments to the HCBS waiver providers, and look forward to CMS approval for the other provider groups. As Emma mentioned, the spending plan included some additional items that we see as opportunities to help improve and enhance home and community-based services. We talked a little bit about one of them earlier, related to helping to provide housing-related supports. So that was one provision that we've included in our spending plan. As Emma had noted, this ability for entities to submit grant applications to improve the infrastructure of the state's home and community-based services programs is another thing that we're working through the details on right now, and still awaiting final approval from CMS. Another item that we included in our spending plan was allowing individuals who are on a waiting list for home and community-based waiver services to apply to receive one-time or temporary services. Could be a limited respite benefit. It could be that they need help installing a ramp in a family home. It could be some things like that. So individuals on the waiting list would potentially be eligible for some of those things. We also included a proposal that we conduct a study and develop recommendations related to how we can, some measures that we can take to address the direct care workforce shortage that we're facing, and have some better ideas about how we might address that issue. We also have a provision that would allow us to develop some family caregiver training to be completed by individuals who have waiver participants living at home, whether it be helping with behavioral supports, helping to relieve caregiver burnout and different things like that. So there's a whole list of additional things that we've included in our spending plan that we continue to wait for CMS approval, and then are working on how we will implement these different elements of the plan once we get that final approval. And Jesse, I think I saw that there was a flash of a question maybe. Okay, do delays in approval mean the funding is extended, or are we losing out on funding when the approval is delayed? It's an interesting question in terms of how all of this 10% funding will work, but essentially we are allowing, on the 5% enhanced funding, we're allowing providers to go back and we will reimburse them for that first quarter beginning April 1 of 2021. They will receive that supplemental payment as long as they have submitted their attestation to us within the first year. So by March 31st of 2022, a provider will have needed to do that attestation. And as long as they do that, we'll go back to the first quarter when the ARPA funding was available. And Eric, if I missed anything there, feel free to.
Yeah. No, so the easiest way to think about this is they've basically given us that extra 10% federal matching funds, and we get to bank those and store those. Think of it, isn't actually what happens, but it's the easiest way to think about it, is store them in a separate account, and then we have those funds to spend through the end, or through March 31st of 2024. And so it doesn't matter if the approvals on those payout plans are delayed. They've approved us to draw that additional 10%. So we will do that and keep those funds so that as we get those approvals, like Tanya mentioned, we can retroactively calculate what that 5% increase would have been to those providers and pay it out.
At least on the HCBS side. We don't have that authority yet on the state plan side, but we did submit the state plan, and we did it under the disaster state plan process at the advice of CMS, because that's supposed to be the expedited process, and we should still be fine going back to April 1st once that's approved, at least on the supplemental payments. So yeah, it's they are the best of bureaucrats. If you think we're bad, they top us, frankly. So any other questions on the ARPA funds? They are in process. I think the first payment we made was what, Eric, to about 211 providers, and it was $3+ million
That's
for
correct.
HCBS providers. So we think that was a pretty good response very quickly from a lot of providers.
Yeah, and actually it was 3.5 million per quarter. So it was about
very
7
good.
million total.
Okay, yeah, so that was the first payment. So we feel good that providers responded so quickly. Michael?
Yeah, just listening to this and then tying it back into the previous conversation with the content in terms of different legislators maybe thinking all provider groups are getting this big increase. If we're focused on targeting reimbursement to HCBS or some behavioral health providers, I think that's going to be an important distinction to make on limiting those discussions to the provider groups that are actually getting those increases. Because you think about how easy it is for that to be overgeneralized to all providers, and maybe just being a little more aware of how this issue is maybe getting conflated with the concerns that I was hearing about and mentioned earlier in the discussion.
I totally agree. And early on, when we had our discussions with the Executive Appropriations Committee and legislative leadership, we were very clear, but you know, memories fade, and there has been a lot of federal money floating out there. So that has nothing to do with Medicaid or our providers, but they do conflate it all together. So.
Thank you. Emma, do you want to just move into consult? Oh, actually, sorry, I'm getting lost on the agenda. The managed care entities vaccine efforts presentation.
Yeah, so I think we had asked that the plans be prepared to give an update on what you're doing with vaccines or what responses you're seeing. So I don't know who's going to do that. Brian, I'm assuming you're doing that for Melina. I can't really see who all's on yet.
Can I just add, we are, you know, that was, I think, a really great conversation on the budget, but we are running low on time. So plans, I think a quick overview rather than, you know, would be preferable if we can at this time. Thanks.
This is Julie. I can go first to speak about so what we are
Julie, we're having a hard time hearing you.
Oh, you are? Give me a second. Let me swap out my microphone.
You're a little faint.
Does anybody else want to jump on while Julie's rejoining, like Todd or
yeah, this
Brian?
is Todd
Okay.
with Select Health. I can jump on real
Okay.
fast and just give a quick update. So since we talked last a couple months ago, Select Health did implement an incentive, $100 cash or gift card, Visa gift card incentive for individuals to get vaccinated. And we have seen a good uptick of individuals getting vaccinated for that. It's eligible for all of our lines of business, but also for Medicaid and CHIP, which is what we're concerned about here. We've been taking a lot of efforts to communicate it out to our membership, including direct mailings, website, social media posts, and working with some community partners and community outreach to do so as well. Our multicultural community relations specialist has done several events where he's been out spreading that word. So if you want additional information on it, selecthealth.org/getvaccinated will give you all the information you really need on it. So I'll just leave it really quick at that since we're so short on time.
Yep, and this is Brian. Similarly, ours is only geared towards CHIP and Medicaid at this point, but we do give those gift cards out as well for I think they're $25 for getting vaxxed.
This is Julie. Can you hear me now?
Yeah, much better.
Okay.
Thanks.
So we've kind of taken a four-prong approach in getting our members vaccinated. The first approach is we've been doing an educational campaign, which consisted of mailing postcards, doing email, creating some videos, explaining to folks that they can get vaccinated at no cost, trying to give them good information about the vaccine to help kind of combat the misinformation that's out there. The second prong is direct engagement. So we've been doing some community outreach in various languages, English, Spanish, and Arabic. As our community outreach team goes out to different organizations, they've been tagging on and, by the way, get vaccinated to some of their presentations. The other thing that we've been doing is some clinical outreach. So our clinical operations team has been calling members who look like they may be late to getting their second shot. We've been targeting members who might be at high risk for hospitalization. And we've actually partnered with community nursing services to give shots in homes to vulnerable patients. And then the other thing we've been doing is we've been taking our list of unvaccinated members and tying that back to our PCP attribution. So if we have a bunch of unvaccinated members who look like they're seeing a particular provider, we're actually asking the provider to reach out to the member, because we know that is more successful when an individual's PCP is talking to them about the vaccine. So we've been doing that as well. Our third prong is we're constantly updating our data. We get dashboards on this to monitor our progress. And then finally, we've also initiated a vaccine incentive where it's a $50 vaccine incentive for our Healthy You members who were vaccinated between September 25th and December 31st. We might extend that program after December 31st, just depending on how successful it is. And we're actually starting a campaign on that one, email and postcard in English, Arabic, Spanish, and Somali. And that will actually be going out tomorrow.
That's great, Julie. Thank you. That's excellent. Okay. And then Christine?
Yeah, so Health Choice is also doing some campaigning. We've also included our care managers to kind of be included in that, and when they're speaking with our members to make sure that they've been vaccinated. And then also we've kind of tried to have our customer service reps be also making sure that they're educating any callers that we receive. And then we put information on our website. We're also doing a $50 gift card. And then our outreach coordinators are making great efforts in any of the events that they're attending, that they're making sure that they're passing out cards to our members and letting them make sure that they are aware. And then and we're also mailing a postcard as well, letting them know of the incentive and the importance of vaccinating. And then our Dr. Ferguson has been on Channel 4 a couple of times talking about the importance of vaccines. And so we're really trying to educate as much as we can and let our members know of the benefit.
Great, thank you.
Awesome. Thank you all. I guess, you can even just put it in the chat. Are you seeing a difference like with the incentives? And I guess to Steph's point too, are you seeing, we talked about this last time, but just how much are you seeing between, the actual barriers that you're able to address to getting vaccinated versus, sometimes this idea versus hesitancy? And if you want to just type in the chat too, but I know that's something that we talked about last time.
So we just started our vaccine incentives, so I couldn't comment on that yet for Healthy You.
Thanks, Julie.
And that goes the same for Health Choice too. I don't think we can really quantify that quite yet.
Yeah, this is Todd, and even with Select Health, we've had ours running since the end of August, and it's still a little early to see in the numbers whether or not it's had an impact on increasing the total number of vaccinations, but it looks like it's trending in that direction, at least having a little effect in getting increased numbers.
We ought to follow up with that like in January or something.
Yeah, I was going to suggest, the data that Brian put together before the report, we're still sending out that data to the plans on a monthly basis. So I think we can probably, maybe do an update to that report, maybe in December or January, and present it to this group.
That'd be great.
Jesse, if that's
That sounds
okay.
good. Yeah.
Yeah.
That'd be great. Okay, awesome. Thank you all. Thanks so much.
Okay, great. Well, looks like I'm up next, and I'm going to apologize too, because unbeknownst to me, since we're all working at home, my neighbor's having their roof ripped off. So you might hear some background noise. I apologize. So, so state agency consolidation. I mean, right now there isn't, again, a lot new going on except down in the nitty gritty. You know, you're all aware of the announcement of the new upper leadership of the new department, which will take effect next July 1st of 2022. And so in that, I think you're all aware that we've got the three sections in the new department: operations, which is all the infrastructure operations to support the department, healthcare administration, and then community health and well-being. And so if you've looked at the website or see the announcement, Nate Winters from DHS will be the Deputy Director over Operations. Amanda Slater, who's currently the Director over Licensing in the Office of Licensing in DHS, will be the Assistant Deputy. For Healthcare Administration, which is where, of course, most of our concerns lie, it will be Nate Checketts, who will be the Deputy Director over that section, and Tanya Hills will be the Assistant Deputy Director over that section. And just to remind everyone that that section will have healthcare delivery and financing, which will integrate Medicaid CHIP, really the bulk of the Division of Substance Abuse and Mental Health and the state hospital. And then long-term services and supports, which will be adult aging and adult services, DSPD, the State Developmental Center, and the Utah Developmental Disabilities Council. So that's where a lot of our focus will be. And then community health and well-being, it's going to be Dave Litback, who's the Deputy Director, and then Heather Borski, who will be the Assistant Deputy Director. And that's a bit of an interesting combination of programs, because it's things like DCFS, JJS, Office of Recovery Services, and then the family health portions of our department, and then of course public health prevention and epidemiology is also part of that. So that is in the works. In the meantime, we are now actually putting together statutory language for the bill that will become the new code for the new department. I think the goal is to try to present at least the bulk of that bill in an interim committee before the session starts, because the senator who is carrying it, who is Senator Andrigg, who's opened the bill file, but he would like it to be a committee bill going forward. And the purpose is not to necessarily make any other substantial changes other than the ones to create the new department, but he has been open to some changes that just make sense. So we're working through all of that right now. And then Tracy has actually asked the deputies and the assistant deputies and others that they would like to involve to start contemplating the next level down of leadership. So there are beginning discussions about that. There are obviously some vacancies that are already existing that are in the works, and so that's the activity that essentially is going on now. So that is pretty much what's happening with regards to state agency consolidation. Oh, I guess I should also comment that, of course, a lot of the discussion around the consolidation of the state agency, the new department, is what does this look like from a budgetary perspective going forward? So there's been a lot of work done on trying to streamline the line items that will exist for this new department. So Eric, do you want to just high level? I mean, right now there are about 19 different line items across all of these, different entities, and I think everyone's now come to an agreement of looking at 10 line items, which I know that doesn't mean a lot to everyone, but this is essentially the different buckets that the legislature is going to fill, so to speak, through this appropriations process.
Sure.
Eric, did you want to say anything more about that? I mean, it's pretty high level.
Yeah, it's very high level, but basically, historically, like I showed in the presentation, we've had separate line items for CHIP and Medicaid. Those will more than likely end up combined within the same line item. The administrative piece will clearly be separate from that. And then other parts of the new combined organization will be in that same line item with CHIP and Medicaid, but with tight controls on those programs that are funded through the Medicaid consensus process.
And that's only the administrative pieces that are in healthcare administration that we're referring to. So not across the whole department. So for instance, there are administrative pieces of substance abuse and mental health, and PRISM will go into that bucket and some of those things. So those are, I mean, some of the things that are going on. They're still working through, Tracy and Nate are working through the process in terms of our building blocks. We're not in a position yet to address those. And in fact, neither Tracy or Nate were available to be at this meeting today, but we're hoping to get them to come to either the November or the December meeting. Probably the December meeting would be the best one, because then the governor's budget will hopefully by then be released, and they can address what the combined budget requests look like going forward for the department. So that's pretty much the update right now on state agency consolidation. Tanya, I know you're involved in a lot of this too. Did you have any other comments that you wanted to make on that? Oh, maybe she had to step off for a minute, or.
No, I think you're on mute, Tanya.
Oh, I did the opposite. Yeah, no, I don't. I think you covered covered all of it.
Okay. And then let me just go to the director's report. So let me just say, on the Medicaid focus group plan for improvements, I think we put this on here to kind of hold all our feet to the fire to make sure that we start addressing this. We don't have anything yet to report on for today, but we will work with our colleagues at Workforce Services, and over the next couple months be able to come back to this group and have some discussion about that, because I know that that's an area of keen interest to this committee. In terms of Medicaid policies, again, like I mentioned in previous meetings. Oh yeah, Jesse, do you want to go ahead before I go on?
Yeah, I just thought I'd jump in really fast with a question from HB 262. There was that study that was requested around disenrollment and why people are losing coverage. And so I just didn't know how that might fit into the focus group discussion, and if that could be something we talk at the next meeting too, but if there were any.
Yeah, actually, as part of our outreach proposal, we were hoping that the marketing entity that we are trying to engage will actually conduct a more in-depth study. I mean, I think the focus groups were great, and it was, you know, I think it was a good first start, but I think we're looking for something even a little deeper in terms of that. And our concern is really trying to find out what the barriers are, and also from the community, what people think. I mean, how can we better reach out, you know, and what are the things that we need to try to fix to basically get them healthcare coverage. So we're hoping that the marketing entity, like I said, that we're talking to right now, will actually conduct that study. That's part of the scope of work. Okay, and then in terms of, like I've mentioned in previous meetings, we have not been doing a lot of work on other policies at this point with everything going on, but I will just mention a couple of items. We had a request to open, I think I mentioned this last time, a code that is specific to pediatric depression screening, really in the primary care setting. So this would be a code that, you know, pediatricians and others could basically bill to Medicaid for taking some time to actually conduct a pediatric depression screening. That code will be open November 1st. It's 96127, and there will be an interim MIB that Medicaid information bulletin that goes out, and it'll be also on our website. We're going to be sending out some flyers to individuals, to our Medicaid eligible individuals in the St. George and Ogden area, but I don't know if everyone's aware that the school, University of Utah School of Dentistry, actually has taken over the old family dental clinics in St. George and Ogden, and those were opened in September. So those are going to be available to our Medicaid members as well, and those flyers will be going out to our Medicaid members in those areas. With regards to the 1115, I think Jesse mentioned the renewal of our overall 1115 waiver, and hopefully CMS gets their portal fixed. I think there was some confusion about what we were doing with community engagement, and as you all know, CMS withdrew their approval of our waiver for community engagement. So part of what we're doing through our renewal process is actually removing all of that language from the waiver. When you see we had CMS put out some updated documents, so hopefully that will be more clear than it is right now. But again, that waiver is not set to be renewed, the overall waiver, until July 1 of next year, but it's literally a year-long process in order to get that done. So, and then we are also submitting 2 new waivers by the end of the year. We've talked about this before, the medical respite care pilot waiver that was created by HB 34, and then the bill is called fertility treatment amendments, but really what it is, it's a waiver to provide services for fertility preservation for individuals, including youth, whose fertility may have been impacted by treatments related to cancer, a cancer diagnosis. And you'll be seeing information on our website, and it'll be publicly posted. We are planning on a public hearing for these waivers on November 15th. It will be a virtual hearing, of course, and then also in the November MAC meeting, we will be presenting these waivers as part of our public hearing process as well. And then just a couple of other items just to note. As you're aware, we contract with a company called Logisticare. They've changed their name now to Motive Care for non-emergency medical transportation. And we are at the end of their 5-year contract, so we'll be going out for another procurement for a non-emergency transportation vendor. And we'll just keep you posted as that plays out. And those are probably, I think, some of the highlights right now, some of the things that we're working on. And then I think you've got the document related to other spas and policy changes. We haven't done a lot of state plan amendments recently either. Really the ones that we've done, we've talked about, which is the disaster relief spa to be able to make the supplemental payments for our state plan service providers. As Tanya mentioned earlier, our behavioral health, our home health, our autism service providers, and our school-based providers. I think in our last meeting, we also talked about the changes we're making to the school-based skills development program reimbursement process. So we've submitted our initial state plan amendment to start that change in authorization. And then we made a slight modification to our disproportionate share hospital state plan, which we've talked about before, but essentially what it allows is if there are any funds left over after all of the other hospitals are essentially, they receive their appropriate share of this funding, that any balance can go to the Utah State Hospital, in addition to what they get under a specific DISH payment for institutions for mental disease. So this helps the state hospital out, which they severely need some assistance in terms of their funding. So those are the state plan amendments that we have submitted recently. And there really aren't too many other things in the works right now. As I said, we've just had our hands full with everything else. So questions Time frame for, oh, okay, good question on that. I don't know if Jen Storhacker is still on the call. It doesn't
I'm
look
not
like
sure.
she
I'm not sure if she is on, Emma. I think she
today.
may have
Okay.
taken the afternoon off. So
Oh,
let's see.
okay.
Non-emergency. Yes. Yeah. The app with the RFP development is in process right now. I'm not sure that we typically put an RFP out for public comment prior to issuing it. Not to
Yeah,
say
we don't typically. I mean, we'd be happy to have folks give some input. I will say that there are not a lot of entities nationally that actually do this work or that would likely bid on this work. I mean, I think we've had some interest expressed in the past, and generally we don't get a lot of actual bids. But we'd be happy to review it, you know, with this group, just to make you aware of what we're putting into this to this RFP. Some of it is driven by federal regulation, and then of course the specific needs of the state. So, and it's about a year out. So we usually, when a contract is going to expire in about another year, because state purchasing generally only allows us to enter into contracts no more than 5 years. And so we're reaching the end of our 5-year contract, and so we're required to go out for public procurement. Even if it ends up being the same vendor, we're still going to have to go out for public procurement to before we can enter into another contract. So.
Okay, that's helpful. I mean, I think it's been a while since I've looked into this area, but I remember hearing some concerns about logistic care a few years ago, or just some frustration. So I guess that's why I kind of my interest, and if there's a way for people that are more involved in dealing with non-emergency medical transportation to weigh in, that's probably a
Yeah, I think we'd appreciate input. I think the other thing that's going to be a challenge is too that CMS just recently came out with some additional guidance with regards to transportation providers and the requirement to actually vet not only the company but all their drivers against the federal database, which is going to create some additional, I mean, it's a good thing to do, but it's also going to create some additional challenges in terms of fulfilling this need.
Yeah.
Are there any questions or other things around that? All right. So we want to turn it to Jeff for one last quick overview of enrollment.
Great.
Sure. So it's good to be with you again after another month. You'll see very similar numbers to last month as we have continued on about the same trends as before. So thank you, Sharon, for pulling up those graphs. If you'll scroll down a little bit, we will show, here's the overall graph for Medicaid. You'll see that we are still increasing overall. The two primary drivers, as you'll see in a moment, are the adults and the children. The new expansion adults and children overall. Children are about to hit the highest mark that children have ever hit in the state of Utah at 215,000 children, or sorry, 222,000 children. So it is really increasing. We've hit that new line for them. But in the last meeting, in the CHIP PAC meeting at 1 o'clock today, we did talk a little bit about CHIP and why those numbers might be decreasing. So we won't go into that here too much today. But overall, you'll see that those trends are very similar. They've continued along the lines that they have in the past several months while we keep and continue to keep cases open. If you'll scroll down, Sharon, to the following graphs, we can kind of show people with disabilities continues to increase slightly. People over age 65 is increasing at about the same rate it has over the past several months. And then pregnant women is the one interesting line here that does decrease slightly, and that was due to a change again at the end of last year, where CMS allowed us to sort people more correctly into the programs that they'll be in post the PHE. So that was an expected trend we would see with the pregnant women. It does not mean that the pregnancies are overall going down, although I believe that is the case if you were to look at that as a whole number. And then finally, if you'll jump to the bottom graph there, if you would, which shows the children, again, hitting that highest peak that we have ever hit in the state of Utah. So that's fairly impressive. On this graph, those lines are separated by 20,000 increments. So that's a large leap over where we were way back in 2015, 16. There's your very brief analysis of what's happening with Medicaid in the spirit of time. Any questions?
Thanks, Jeff.
You're welcome.
Jeff, thank you. I think, you know, in the interest of, so some of the people that were not at the CHIP Act might not have heard about some of the, like the marketing agency that Emma mentioned earlier. Like there are a few things that I realized were mentioned at the CHIP Act that maybe didn't get mentioned here. And I just didn't know if it, like you could give the very quick mention of that too, since I think it ties into some of this as well.
Sure. Very quickly, we are working, as Emma mentioned again before, that we are working to get a group. The state is contracting now at the state level with a group that will come in to do some of the work you mentioned in House Bill 262. So the survey you mentioned, and then working again, trying to really market to kids overall. That's in CHIP and in Medicaid. And it doesn't matter which one you market, you'll get an increase in both programs, is our experience over the past years. So we're excited to take that work on and see what this new agency can help us with, and what a good time to bring them on too, to help with maybe some social media, increasing social media usage, and maybe even helping us with some of the unwinding efforts that will occur whenever they occur.
And we did also specifically in the scope of work also wanted a specific campaign targeted at the Latino community, because we realized that is an area where Utah does not look good, and we need to get those kids coverage. So there will be that as well. And as we talked about in the earlier meeting in the CHIP Act, you know, our traditional methods of reaching out to families and making them aware of Medicaid and CHIP and encouraging them to apply. You know, they were somewhat successful back then, more difficult now with the pandemic still occurring, because there was a lot of face-to-face and that type of thing. But one of the things we talked about earlier was, what can we do also to engage the schools? Again, you know, we typically every year, you know, the plans work with us to send out some flyers to all the schools to make sure that families are aware as school's coming up and it's time for immunizations. But the schools are also a great source of contact with families to say, you know, again, your children might be eligible, and by the way, please keep your addresses and your contact information. You know, if you are currently eligible, make sure that that's updated so you don't become ineligible. So we're going to try to utilize the schools again, which I think was a great idea. And also primary care, again, you know, pediatricians, general docs who are seeing kids, trying to engage them more in trying to get the word out. So I think we are open to ideas. So if you have thoughts, please send them to myself or to Jeff, or, you know, you can send them to Sharon, and she will. That's probably the easiest thing. Send them to Sharon, and she'll make sure that we get them. But as we engage this marketing firm, one of the things we're really looking for that we haven't done in the past is really maximizing social media, because that does seem to be where we're all getting our news and information, and we've never really taken that approach before. So if you have other thoughts, please let us know.
All right. Well, and I think that could also be an area of interest too, especially the study for the MCAC too, and maybe something that we could, whether it's for this marketing agency or elsewhere, but I think it's certainly an area of interest, that something we've talked about for years. So maybe that could be an agenda for the MCAC too, to discuss in more detail as well.
Yeah, I agree, especially with the idea that this is really a campaign targeted at children just overall. And you know, I think it's a good time too, as we're doing the unwinding, of making sure that those kids are still staying and getting the coverage they need. So we can provide periodic updates at this meeting.
All right. Are there any other updates, questions, thoughts, news? Okay. Well, thank you all. Thanks so much. We will have our next meeting on November 18th. And if you have any questions before then, please feel free to reach out to any of us, Sharon, Emma, myself. And we'll see you on the 18th. Thanks, everybody, and happy Halloween.
Thank you.
Bye.
Thanks.